and the University of Muhammadiyah Malang. We also proudly announce there were participants from Brazil, from Egypt, Yemen, Gambia, Malaysia, Vietnam, Philippines, and Indonesia who had finished the international short course. With lecture and participants from various countries, interesting learning methods with interactive discussion. I believe this program provides great opportunities to the student in expanding the network and achieving learning outcome covering aspect of attitudes, knowledge, skill, and ability relevant to the health issues, as well as improving interpersonal and interpersonal skill, such as communication skill, leadership, time management, and problem solving to face world challenge. And the end of this activity, committee has done the evaluation of the learning process, and those who meet the requirement will get a certificate of graduation from this international short course, which can then be covered according to the policy and institution of origin. Once again, I would say thanks you for the lecture and participant who made this international short course successful. I hope this event will be sustainable every year and track more international students from more countries. Once again, thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Yoyo, for wonderful remarks. And before the lecture started, I would like to invite some students to give testimonial related to their experience on this course. We have from Vietnam students. Seems like we have the video recorded. Maybe you can play, Mr. Zaki.
Hello everyone, my name is Tuan Anh from University, Vietnam. Firstly, I want to say that I'm very happy to be a participant in the International Short Course 2022. Well, at first, I have a little bit scared when applying for this course because it is presented in English, which is not my mother tongue. So I thought that it would be a barrier for me to follow the course. Fortunately, till now, I can understand nearly 70% what you were saying. It's really lucky for me thanks to the support of the speaker and the staff during the learning time. Honestly, the topic of this course, therapy on musculoskeletal neurology disorders, is the topic that I have led chance to be learned before. However, the way the speaker talk about this topic made me easy to understand and follow. I have learned many useful knowledge from this course, and I hope that I can apply it in my further career to take care of my patient better. Finally, last but not least, I want to give the great thankfulness to all the speaker, organization department, as well as the staff for creating a helpful course like this for me and my friend in the University, Vietnam. Thank you very much.
You're welcome. This is Hong. I hope I spell your name well, Huang Phu Van from Vietnam. And we have Oma. It's a Yemen student who stays in Indonesia. Maybe Miss Sydney can play the video.
Hello guys, today here I'm gonna talk about this international short course. During this course I have learned so much thanks to all the wonderful teacher at International Short Course. The course is structured in a very efficient and good way and give you the knowledge that facilitates your university studies. Everyone is extremely professional, kind, supportive and helpful. from the start to the end of the course. Again, thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Omar. Actually, Omar will join you today, but seems like the Wi-Fi is going trouble because we have heavy rain here. And the last student will be from Malaysia, Nurul Amira. Would you give us the live testimony? I can see.
Okay, I'm sorry. I was actually on the voluntary work. Okay. First of all, hi. I'm Nurul Amira Tanjung Anan. I'm Myra from University of UITM from Malaysia. Okay. First of all, I want to say thank you for allowing me to participating in this international short courses. It's a great opportunity for me as I can gain new knowledge, new things about other people. And also, I want to say thank you for making this free, so I could have this without any payment. And actually, these courses has helped me with my assignment lately, especially for the
Oh, really? That's great, huh?
Yeah, so I was lucky then. All right, so that's all from me. Thank you for having me.
Thank you, Nurul, and good luck with your volunteering. And maybe that's all from the closing ceremony, dear student. I would like to thank you all for all the presenters and audience for the participant in this activity. And without any further ado, dear student, we have Dr. Nailis Syifa here. Good morning.
Hi. Good morning.
I will spotlight you. Wait. Okay. Good morning in Brazil, but here we have good evening, maybe. We are very grateful to have you here today. Dr. Nailis Syifa will present about stroke treatment and medication using case study approach. Okay, the time is yours.
Thank you, Ms. Virasti. Hi, the student. Hi, all. So in this opportunity, thank you for this opportunity. I would like to present about the stroke treatment and medication, the case study approach. But before we going too deeply in the case study of the stroke treatment, I would like to present about the stroke, what is stroke, the definition and the pathophysiology, and also the manifestation, clinical manifestation, and the treatment. So what is the stroke? Stroke involves abrupt onset of the focal neurologic deficit that lasts at least 24 hours and is presumed to be of vascular origin. Stroke itself is neurological disorders, which is characterized by blockage of blood vessels. The clots form in the brain and interrupt blood flow, and clogging arteries and causing blood vessel to break, leading to bleeding. Rupture of the arteries will lead to the brain during stroke, results in the sudden death of brain cells owing to a lack of oxygen. Stroke itself is classified by two groups. First is ischemic stroke, and the second is hemorrhage stroke. Ischemic stroke is ischemic occlusion contributes to around 85% of causalities in stroke patient, with the remainder due to intracerebral bleeding. And this ischemic stroke is divided into two. That is thrombotic and also embolic condition. And how about the hemorrhage stroke? Hemorrhage stroke accounts for approximately 10 to 15% of all strokes and has a high mortality rate. In this condition, the stress in the brain tissue and internal injury cause blood vessels to rupture. And hemorrhage stroke is classified by intracerebral hemorrhage, subarachnoid hemorrhage, and also subdural hemorrhage. So we can know the deeply how about the molecular mechanism in the stroke. Next slide, please. So as I said before, that stroke is classified of ischemic stroke and hemorrhage stroke. These two of stroke can cause the brain injury. In ischemic stroke, by clot obstruct blood flow, and in hemorrhage stroke, which is causes bleeding, two of those can promote the brain injury. So how about the mechanism in the brain injury? There is some mechanism in the brain injury, such as the excitotoxicity and also neurochemical injury, neuroinflammation, blood-brain barrier dysfunction, and interruption of blood flow. Excitotoxicity can lead to influx of the iron, calcium, and natrium, which can lead to depolarization and free radical mediated toxicity. While neurochemical injury will lead to oxidative stress and lead to edema. And also in the interruption of the blood flow can increase the intracranial pressure. So all of these mechanisms can lead to the cell death and can cause cerebral damage. Next slide, please. Okay, so what kind of the clinical manifestation in stroke? There is a sign of stroke in men or women, such as the neurological dysfunction we can see here, such as the numbness or weakness in the face, arm, or leg, especially on one side of the body. And then there is a confusion or trouble speaking or understanding speech. And also there is a sign trouble seeing in one or both eyes. There is a trouble walking and also problems with the balance. And some patients have a severe headache with unknown cause. This sign of stroke basically depend on which area in our brain is affected. So during stroke, every minute counts. So it is very important. The fast treatment can lessen the brain damage that stroke can cause. So by knowing the sign and symptoms of stroke, you can take quick action and perhaps save a life. So the stroke treatment that work best are available only if the stroke is recognized and diagnosed within 3 hours of the first symptom. So that's why we need to know the clinical manifestation in the stroke patient. Next slide. So now we go to the stroke management strategies. There is some management of stroke. First is stroke acute care. How to manage the stroke acute care? We can manage the risk factor of the stroke. Stroke have the risk factor which is modifiable and unmodifiable. Unmodifiable risk factors such as the age and also ethnics, but there is modifiable risk factors such as blood pressure, which is related with hypertension and diabetes, and also alcohol and drugs and hyperlipidemia. In this risk factor, we all know that hypertension is one of the predominant risk factor for stroke. In some study, a blood pressure of at least 160 per 90 millimeter and a history of hypertension were considered equally important predisposition for stroke, which is 54% of the stroke affected population having this characteristic of the blood pressure. And the second stroke management strategies is reperfusion. In the reperfusion, usually the therapy use IVT or intravenous thrombolytics. But however, if we know about these thrombolytics, there is such as very important inclusion and exclusion criteria, since the thrombolytics can cause the bleedings. So this thrombolytics therapy need to be highlighted and make sure that patient need this thrombolytics therapy. And also there is a golden periods by using this thrombolytics. And the rehabilitation management for stroke, such as the physical therapy, occupational therapy, speech therapy, and neurorehabilitation. This rehabilitation, usually we can use post-stroke, so post-stroke therapy, because some patients usually have some neurological deficits, such as difficulty in the speech or difficulty in the motoric and others. So some patients need rehabilitation. And also there is a cognitive decline, such as the robotics and stem cell therapy. And the last but not least, there is a neuroprotection and repair. This neuroprotection usually need in the patient to reduce the or to prevent the stroke recurrence, such as citicoline and piracetam, which have effect as a neuroprotectant. Okay, and then next slide. So in the stroke patient, some of the medication that usually give in the stroke patient, as I said before, recombinant tissue platelet activator or RTPA, which have very tight inclusion and exclusion criteria. In the giving a patient who give this medication should be monitor the blood pressure, neurological function, and the most important is also bleeding. And the second classes is antiplatelet therapy, such as aspirin and also clopidogrel, ticlopidine, dipyridamole. This kind of drug is classified as an antiplatelet therapy. In the antiplatelet therapy, patient also need to monitor the bleeding, because as we know, especially if the patient give the combination of this antiplatelet therapy, so it should be monitored about the bleeding. And warfarin. Warfarin is classified as an anticoagulant. It is also need to be evaluate about the bleeding, INR, or hemoglobin. How about the hemorrhagic stroke? Actually, the ischemic stroke and hemorrhagic stroke have a different or very different pathophysiology or causes. So in the therapy also have a different. In hemorrhage stroke, nimodipine as a first-line therapy for subarachnoid hemorrhage. Patient who give nimodipine should be monitored the blood pressure and also the neurological function. Okay, next slide. So now we are going to explain or discuss about the case study of the stroke. In this presentation, I take the example about the ischemic stroke. So BS, or the patient, is a 73 years old man who sent to the emergency room after noticing dysphagia. He started experiencing speech defect 1 week ago. Next slide. Before. Okay. So this patient is noticing dysphagia and he started experiencing speech defect. So there is a speech defect 1 week ago. He denied any motoric weakness. How about the past medical history? There is a note about the past medical history. The patient got a lateral fracture and insertion of a pen on the right side, and also patient have a hypertension and diabetes mellitus, but it is controlled well. Next slide. How about the past medication history? This patient take the Nopertan and also aspirin as an antiplatelet once daily, 1 tablet once daily, and vitamin B, also 1 tablet once daily, and metformin to control his blood glucose, and calcium lactase. Next slide. The patient then diagnosed with cerebrovascular accident infarct and dysphagia. Stroke, also called as a CVA or cerebrovascular accident. So this is the same name. So patient diagnosed by stroke, infarct, and dysphagia. Okay, and then next slide. We can see this is the clinical data or the objective data of the patient. Patient were hospitalized for a 12-day. There is a data about the temperature, blood pressure, pulse, and then some of the patient condition. For along the 12 days, we can see here that the temperature related stable. But in some of the days, the patient got a little bit high temperature or febrile. How about the blood pressure? The blood pressure of the patient also stable, but in some of the days, there is an increasing of the blood pressure in the day 3, 4, 5. There is a blood pressure around 159 per 90. And patient have no nausea and have no vomiting, but patient have a cough and dysphagia. So in this case, if we see from clinical data of the patient have a dysphagia. Okay, next slide. This is the table of the laboratory data of the patient. Some of the data about the hemoglobin, white blood cell, BLT, and also blood glucose levels, and some of the renal parameter, and also albumin and cholesterol. We can see here that the hemoglobin is in the normal range, and also white blood cell, also in the normal range. In the blood glucose of the patient, it also shows that it's still controlled. And for the cholesterol of the patient, it is also controlled. And then next slide. There is some medications that giving into the patient. The first medication is citicoline in the 3 times a day, 500 milligram IV. It is given in the day 1 to the day 12. And patient also give by ranitidine, 1 ampoule, intravenous, and twice daily. It is also given in the day 1 to day 12. The patient also got the antiplatelet. First, the patient give by aspirin, once daily tablet by oral or orally in the day 1 and day 2. But after that, the patient switch or change from aspirin to clopidogrel. The clopidogrel given also orally in the day 3 to the day 12. Patient also got anti-hypertension therapy, lisinopril, which is a ACE inhibitor, once daily and orally in the day 6 to 12. The patient also give some medications such as the paracetamol and also vitamin B and terazosin hydrochloride. This terazosin hydrochloride is given to the patient because patient have a symptom difficulty in the urinating. Okay, and then next slide. So now, from those medical record of the patient, we can take some questions. First is which sign, symptoms, and other tests indicate the presence of stroke or cerebrovascular accident. To answer this question, let's see from the first data, the patient data in the slide 7. So in the slide 7, okay. In here, we can see there is a sign and symptom of the patient, which can indicate that patient have a stroke, such as the dysphagia. So this symptom, dysphagia, is one of the primary symptom in this stroke case. And also the patient experienced by speech defect. Okay, in the first explanation, we know that some of the stroke symptoms is a speech defect. It is depend on which brain is affected. Okay, and then in the clinical data in the slide 10, we also can see that the patient have dysphagia. So this is one of the signs and symptoms of the stroke. Okay, we go to the slide 13. The next question, identify the non-modifiable and modifiable risk factor. Okay, we also go to the case study. So from this patient, we know that in the slide 7. So what is the risk factor of this patient? If we can see from here, the past medical history, the patient have hypertension and also diabetes mellitus. As we know that hypertension is a risk factor for stroke, and also there are many reasons for high of blood pressure in the stroke, including the history of hypertension, and also maybe increase the intracranial pressure in the stroke patient. And some of the reason also can link with stress, because patient admitted to the hospital, and also maybe patient feel painful, so it maybe can reach the hypertension. But in here, the patient have the history of hypertension, so this hypertension can be explained as a modifiable risk factor in this patient. And the second risk factor, we can see here that there is a diabetes mellitus. And we know that hyperglycemia or elevated blood glucose is common in the stroke patient. So in stroke patient, by targeting the blood glucose level is an efficient for stroke management strategy. And we also know that the past medication history of this patient already take metformin to control his diabetes mellitus. So this is one of the risk factor, modifiable risk factor. Another risk factor that we can see here is age. The patient is a 73-year-old, but this is unmodifiable risk factor. Okay, and then next question. Identify the treatment's goal of the patient. Okay, we can see from the medication in the slide 12 that a patient have given of some medication, such as the lisinopril. This is an antihypertensive agent. So because the blood pressure of the patient show the increasing in some of the day in the history, so that one of the goal treatment is to control of the blood pressure of the patient. And also because patient show the symptom dysphagia, so to reduce those dysphagia also one of the management or goal therapy in this case. And patient also get the citicoline. The citicoline is a neuroprotectant. So also the treatment or goal of treatment, the next is to prevent the recurrent stroke in the patient. That is the secondary goal treatment in this patient. Okay, the next question. Create the least patient's drug therapy problem. So we can see the next slide. In the therapy of the patient, first of all, the patient problem is a weakness. So one of the patient symptoms is a weakness. And then the therapy given here is IV and S. And this infusion therapy aims to stabilize the patient condition and fluid and electrolyte balancing, and to treat hyponatremia. The second patient got ranitidine twice daily, and this treatment aims to prevent the stress ulcer. We know that ranitidine is classified as a histamine receptor antagonist that can reduce the amount of acid produced by the cells in the lining of the stomach. So in this patient, giving ranitidine is to prevent stress ulcer. ulcer. The second patient's problem is fever and pain. From the data, we know that some of the day patient have fever, and giving a paracetamol 3 times a day, 500 milligrams orally. This treatment aims to reduce fever. And then the next slide. For the infarct or stroke patient, the subjective of the patient is dysphagia. From this subjective condition, the patient gives the citicoline. As I said before, that we know that citicoline is a neuroprotection for stroke, and also it can prevent the death of the brain cells located close to the area of the brain damage. And then patient give aspirin once daily tablet orally as an antiplatelet to reduce long-term cell death and disability. But in the day 3, aspirin switched to clopidogrel, which is the same classified as an antiplatelet. To reduce change, having another stroke or transient ischemic attack or TIA. In some of the journal, there is an evidence that in patients with minor ischemic stroke or high-risk TIA, those who receive a combination of clopidogrel and aspirin had a lower risk of major ischemic events. But also, if the patient give the combination, so there is a higher risk in the bleeding because the antiplatelet were combined. And the next therapy is a vitamin B supplementation, once daily tablet orally. This vitamin B is to prevent recurrence of the stroke. In some journal, we found the evidence in the meta-analysis study. It was found that vitamin B supplementation can significantly lower the plasma levels of total homocysteine to reduce the recurrence of stroke and decrease the combined incidence of myocardial infarct. So this vitamin B complex aims to prevent recurrent stroke. And then next slide. For the hypertension of the patient, this patient is giving with lisinopril once daily, 10 milligram orally. This lisinopril is an antihypertension and as classified as ACE inhibitor or angiotensin converting enzyme inhibitor. In some of the journal, the evidence of lisinopril, even at small dosage, is well tolerated and an effective hypotensive agent after acute ischemic stroke. Gradually can reduce blood pressure by 4 hours after oral first dose administration. And also for hypertension therapy, we know that ACE inhibitor is one of the first-line therapy in the managing of the hypertension in the stroke therapy. And then the patient also have the difficulty urinating, so there is a terazosin hydrochloride 2 milligram orally once daily. This is to treat difficulty urinating. From the pharmacological effect, we know that this terazosin hydrochloride also have the anti-hypertensive agent. But in these cases, this drug aims to treat difficulty urinating because the terazosin hydrochloride not a first-line therapy as an anti-hypertension in the stroke therapy. And then we go to the next question, the last question in the slide 13. What is in the slide 13? Go to slide 13. The next question is, what is the outcome evaluation? And information need to be educated to patient. Okay, we go to slide 17. Since the patient have symptom of dysphagia, so the outcome evaluation, we need to know the dysphagia of the patient, and also one of the stroke outcomes are measured based on the neurological status. So how to measure the neurological status in the stroke patient? One of the parameter can be used is the NIHSS, or the National Institutes of Health Stroke Scale, which contain some of the point or question to the patient stroke, including the motoric and also verbal, and also eyes, and some condition in the patient of the stroke. And the last question is the patient education or to the family of the patient. We need to educate the patient to modify and monitoring the risk factor, especially the modifiable risk factor, such as the cholesterol, diabetes mellitus, and also hypertension. Okay, this is the reference that I use for this presentation. I think that's all for my presentation. Thank you.
Thank you. Ms. Nailis, Dr. Nailis. And we have a question here from Rakitya that she would like to ask about the use of mannitol in stroke. When will we need to administer the mannitol? Oh, because in the case study we cannot see the mannitol. Maybe you can answer.
Okay, thank you, Ms. Radit, for the excellent question about the use of the mannitol. Yes, mannitol is one of the therapy or drug in the stroke, but mannitol is usually used in the hemorrhage stroke, can be used in hemorrhage stroke. So because stroke have classified as two, hemorrhage stroke and ischemic stroke, and then the therapy is quite different between those two strokes. So the mannitol is administered in the hemorrhage stroke, which is in the hemorrhage stroke, the pathophysiology is because of there is some bleeding in the brain, and then those bleeding can make the change of the placement in the brain. So that's why there is maybe some increasing of the intracranial pressure, and this mannitol can use for the increasing of the intracranial pressure. So it is usually used in the hemorrhage, for a hemorrhage patient.
Thank you, Dr. Nair, for the answer. We have another question from Omar Salem. Does food have a direct relationship with stroke? And what is the best way to treat a person with a stroke on the right side of the brain? So specific, Omar, right side.
Okay, thank you, Omar, for the nice question. So for the food, food is related with, if we talk about the risk factor in the stroke, so food is related with cholesterol. Yeah. And then one of the modifiable risk factor is cholesterol. So we need to manage the cholesterol, because some of the food can make the stroke worsen, such as the oily food maybe can increase the total cholesterol and can decrease the high density level of the cholesterol. So it is kind of the dangers some of the foods such as the cholesterol food. And then what is the best way to treat a person with a stroke on the right side of the brain? So we go to the pathophysiology of the stroke. Our body contain of two brain in the right brain and also left brain. The left brain uh, is controlling in the right side of our body, and then the right brain control the left side of our body. So actually it depends on which area in the brain that is attacked. For example, there is amygdala. If we know one of the brain part is amygdala, it is control, or the function is to control the memories. So if the amygdala is attacked, so maybe stroke patient can have the loss of memories. Some of the memories is lost. And also, for example, if there is some part in the brain that control of the motoric, so patient will get a symptom motoric weakness. So in here, how to treat the right side? Actually, for the treatment is the same management, such as the hypertension, if there is a higher blood pressure, and also managing blood glucose levels, managing cholesterol with some drugs such as statins, which is statins can also stabilize the plaque. And also, we cannot, we need to highlight it about the post-stroke treatment or post-stroke rehabilitation. If the right side of the brain, it means that the left side of our body is impacted. So how to manage that? Maybe we can use the treatment if there is a verbal, so there is a verbal therapy, and if the motoric is attacked, we need to rehabilitation with the motoric with a physiotherapy for a motoric treatment for the stroke patient. So basically, to answer this question, it depends on which area in the brain that is attacked. Thank you.
I hope it can answer your question clearly.
Okay, thank you, Omar.
Okay, maybe the last question from me, Dr. Nailis. Why is in the case study I cannot find the RTPA that you said before, that the plasminogen activator is so important for the reperfusion of the blood vessel.
Okay, thank you, Ms. Firasi, for the nice question. So RTPA is the first line of the, not the first line, the first therapy we can give to the stroke patient, especially ischemic stroke. So there is a highlighted point that RTPA is used for ischemic stroke because RTPA is a thrombolytic. And RTPA, if we can see from some of the medication in the stroke patient, maybe it's very rare to be given in the stroke patient. Why? Because the effect of this RTPA is bleeding. So there is some inclusion and exclusion criteria. The patient who will give RTPA. The patient will give RTPA especially when the patient have a golden period, usually for 3 hours in the first onset of the stroke. But after those 3 hours, RTPA cannot be given to the stroke patient. And also, we need to know such as the bleeding history of the patient. Maybe patient have the history operation or some surgery that maybe have some bleeding or risk factor of the bleeding. So RTPA cannot be given to that patient. So basically, if we can see, RTPA is very rare given to the patient with stroke because it have some inclusion and exclusion criteria. Okay, thank you.
Thank you very much, Dr. Nailis, for giving us such informative and amazing explanation. Okay, student, maybe that's all. The end of the international short course session. I do hope all the questions have been answered clearly by our speakers. And thank you for all the participants to actively participate in this session. And I want to invite you to turn on your camera because this is the last session. And I would like to invite Mr. Zaki and Mr. Huda for assisting us to the documentation session, please. Okay, can you please turn on your camera? Or is it too early? I think in Brazil, it's too early in Brazil. 8 a.m. Okay. Maybe you can start from the first page. And the second page, please. Is it done? Okay. 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 Representing the committee, we apologize for any shortcomings and mistakes in guiding the event. And I would like to remind that the certificate of the participant will be sent to the email from Mr. Huda. Okay. Thank you all. Have a good day. Assalamualaikum warahmatullahi wabarakatuh.
Podcast original Spotify, kisah horor The Secret Riana.
Menjadi hebat itu tak hanya berwawasan luas, tapi juga memberi makna. Suasana belajar yang penuh motivasi dan prestasi membuatku makin yakin, inilah aku dan inspirasiku.
Di sini, kamu ditempa menjadi pribadi hebat dan bermanfaat.
Di sini, aku hadir bersama mimpi-mimpiku, melangkah satu demi satu untuk masa depan. Suasana Malang Raya yang sejuk dan nyaman menjadi tempat yang sempurna untuk belajar, berproses, dan menempa diri. Siapapun akan jatuh hati pada kota ini. Impian para pelajar dari berbagai budaya dan negara. Universitas Muhammadiyah Malang diberkahi puja-puji keindahan alam. Kampus ini penuh prestasi. Tak heran, pengakuan dari berbagai lembaga, baik di tingkat nasional maupun internasional, tak henti-hentinya diraih. Mulai dari akreditasi institusi dengan nilai A dari BAN PT, hingga anugerah kampus unggul dari Dikti Wilayah 7 Jawa Timur sebagai kampus paling unggul 11 kali berturut-turut. Di tingkat global, tak kalah hebatnya, UMM 2 kali meraih ASEAN Energy Award, apalagi pada tahun 2010 sampai 2011, UMM juga mendapat predikat bintang 2 dari lembaga bereputasi internasional QS Stars World University Ranking. UMM juga sudah menjadi Associate Member AUNQA, Asosiasi Universitas ASEAN. Mahasiswa UMM sangat beragam. Mereka berasal dari berbagai penjuru tanah air dan mancanegara. Ada 11 fakultas dan 57 program studi yang dimiliki UMM, mulai dari diploma, sarjana, hingga master, dan doktor. Bahkan sudah ada 4 program studi yang terakreditasi dan tersertifikasi internasional oleh AUNQA. Pilihan program dan program studi yang ada di kampus ini seperti Fakultas Agama Islam, Fakultas Ilmu Sosial dan Ilmu Politik, Fakultas Keguruan dan Ilmu Pendidikan, Fakultas Pertanian dan Peternakan, Fakultas Hukum, Fakultas Psikologi, Fakultas Teknik, Fakultas Kedokteran, Fakultas Ilmu Kesehatan, Fakultas Ekonomi dan Bisnis, program magister, dan doktor. Setiap fakultas dan program studi punya sarana laboratorium yang sangat lengkap. Semuanya terpusat dengan laboratorium sentral UMM. Laboratoriumnya juga sudah teruji karena telah meraih ISO dari Komite Akreditasi Nasional atau KAN dan berkualifikasi melakukan uji laboratorium untuk pihak luar, baik perusahaan maupun perguruan tinggi lain. Selain fasilitas akademik, UMN juga punya banyak unit usaha yang bisa menjadi income center bagi universitas. Berkat unit-unit usaha itulah, biaya operasional kampus tak hanya tergantung pada dana dari mahasiswa saja. Ada UMM Dom, UMM Hospital, Rumah Sakit Surya Medika Sumbawa, SPBU UMM, bengkel motor dan mobil UMM, Micro Hydro Power Plant, Apartemen Sang Surya UMM, BPR Rinjani UMM, Pusat Produksi Pertanian UMM Farm, Taman Rekreasi Sengkaling UMM, Race Hotel UMM, serta Kapal Garden Hotel UMM. Semua unit usaha ini juga jadi laboratorium terapan, sehingga iklim kewirausahaan mahasiswa jadi lebih terasa. Reputasi internasional juga menjadi salah satu kebanggaan kampus ini. Ada banyak kerjasama internasional yang rutin dilakukan UMM, seminar, konferensi, penelitian, hingga pertukaran mahasiswa, staf, dan dosen dengan banyak sekali universitas dan lembaga dari luar negeri. Sampai saat ini ada 111 perguruan tinggi maupun lembaga pemerintah dan non-pemerintah dari 31 negara di dunia yang telah berkolaborasi dengan UMM. Di antaranya yaitu konsorsium 22 universitas di Australia melalui The Australian Consortium for In-Country Indonesian Studies, konsorsium 33 universitas di Asia dan Eropa dalam program Erasmus Plus Komisi Uni Eropa, US Peace Corps, Akademi Al-Haramain Saudi Arabia, Korea Energy Economics Institute, Kemko Korea, Temasek Foundation, Confucius Institute Tiongkok, juga Sakura Foundation Jepang. Mahasiswa dan dosen UMM juga terbiasa kreatif dalam mengembangkan riset dan berkarya untuk pengabdian masyarakat. Semangat berkarya.
Social skills mahasiswa benar-benar ditempa. Ada kuliah kerja nyata, pengabdian masyarakat oleh mahasiswa, program pengembangan desa mitra atau PPDM, dan banyak lagi lainnya. Makasih ya Pak. Dosennya pun gak kalah berprestasi lah. Community engagement dilakukan lewat berbagai cara, mulai dari pembinaan desa wisata, pertanian, hingga kemitraan. Kelas praktikumnya sangat menantang, karena dosen beri tugas mahasiswa.
Okay, everyone, we'll close this meeting.